Good morning. I'm Dr. Bhaskar Purushottam. I'm the Endovascular Fellow at Mount Sinai Medical Center. So today I'm going to talk about the Excite trial, which was presented at the TCT this year. So before I start talking about the trial, I'll just give you a couple of slides, a brief introduction about femoropopliteal restenosis, because this was the case we did this morning. So femoropopliteal restenosis, the incidence has been reported anywhere from 19 to 37% in all the clinical trials, and usually involving lesion length of up to 150 millimeters. Now, the best number to remember is probably 30 to 40%. And when the patient has a balloon angioplasty done for the in-stent restenosis on the first occasion, the second time when it recurs, the chances are as high as 60%. And as you can see on the slide, it's almost up to 60% at 3 years with longer lesions. So a Japanese group classified the in-stent restenosis into 3 categories. So class 1 was called the focal in-stent restenosis group, involved lesion lengths less than 50 millimeters in length. And then class 2 is the diffuse in-stent restenosis group, with lesion length greater than 50 millimeters in length. And finally, class 3 were the totally occluded in-stent restenosis group. Now, currently there are several therapies available for management of femoropopliteal ISR, and starting from standalone balloon angioplasty, which has significant re-restenosis rates, cutting balloon angioplasty, then you got repeat stenting with using the same nitinol self-expanding stent or covered stents, which again the results have been very mixed, and covered stents has shown some promise. Then you can also use drug-eluting stents like the Zilver PTX, then the drug-coated balloons, which have now just recently been FDA approved. Also they've used excisional atherectomy, but again there are warnings as to using certain kinds of atherectomy devices in the ISR, and finally the laser atherectomy. And you'll also see some trials and studies where they've used a combination of these therapies. So with this background, I would like to talk about the Excite ISR, which is the Excimer laser randomized control study for treatment of femoropopliteal in-stent restenosis. So I would like to thank Dr. Dippel for these slides. So as I said earlier, this study was presented in TCT 2014, and once the study was presented, the FDA was so impressed with the data that currently this is the only approved atherectomy device treatment for patients with in-stent restenosis in the femoropopliteal segment. So definitely something very exciting in the field of peripheral arterial disease. So this was the study design. Essentially, it was a prospective randomized multi-center trial which wanted to evaluate the safety and clinical efficacy of laser therapy treated along with balloon angioplasty versus just standalone balloon angioplasty in femoropopliteal in-stent restenosis. The principal investigators were Dr. Dippel and Dr. Walker. So they enrolled around 250 patients from June 2011 to Feb 2014. So around 40 clinical sites were involved in this trial. So finally, they had 169 patients randomized to the laser arm and 81 patients to the PTA arm. So it was in a 2:1 fashion. And finally, the numbers with regards to primary safety was 155, and under the balloon angioplasty arm it was 73, and similarly for primary efficacy at 212 days, the final numbers which they used to perform the analysis was 117 in the laser arm and 56 in the balloon angioplasty arm. So these were the study sites, and Mount Sinai Medical Center was one of the study sites. So Spectronetics manufactures these 2 laser atherectomy catheters, the Turbo Elite, which is most commonly used, and their recently one which is called the Turbo Tandem, which we used in our patient this morning with excellent results. So the inclusion criteria, the key inclusion criteria was any ISR lesion greater than 4 centimeters, Rutherford classification 1 to 4, a reference vessel diameter greater than 5 millimeters and less than or equal to 7 millimeters, and at least one vessel infrapopliteal runoff. The key exclusion criteria was any target lesion greater than 3 centimeters beyond the stent margin and any untreated inflow lesion. And also grade 4 or 5 stent fracture was excluded. So as far as the stent fractures, they are graded from 1 to 5. 1 means a single stent fracture, one means a single stent strut fracture. 2 means multiple struts are fractured. Then 3 means there is a lot of fractures, but they are not dislocated, meaning nothing is protruding outside the vessel. And 4 and 5 means it's dislocated, the architecture is severely disorganized, and the struts are sticking out. And the top box essentially were what we see in real life experience, and these were the patients who were included in the trial. So therefore it was a very well done trial simulating real world experience. Now the follow-up was at discharge at 30 days, 6 months and 1 year post procedure. So the primary endpoints were as follows. Number 1, the primary safety endpoint, which was major adverse events all the way through 30 days, included death or unplanned major amputation or target lesion revascularization. Then primary efficacy endpoint, which was essentially freedom from clinically driven target lesion revascularization at 6 months. And this was using duplex ultrasonography binary restenosis, return of clinical symptoms, or deteriorated ABI or Rutherford classification. So if the ABI became worse than So if the ABI dropped by more than 0.15 or the Rutherford classification dropped by 1 category, it was considered significant. So they also performed a power analysis for the study and came up with the following numbers to make sure that the study was adequately powered so that we could acknowledge the results were quite authentic. So this is the sample size determination where they did a power analysis to ensure that the study was adequately powered. So these are the baseline characteristics, and when you look at the patient demographics, you had the standard coronary and cerebrovascular risk factors, and as you can see, they are pretty well matched, and it's also a representative of some of the factors which are predictive of in-stent restenosis. And you can see that almost 1/3 of the patients in both the arms had a previous in-stent restenosis. Then as far as the baseline lesion characteristics, the mean lesion length was also approximately 20 millimeters, which represented real world experience. And you can see that there was more calcium in the laser arm, and rest of the lesion characteristics, there wasn't any significant difference. Now, more than 20% of the lesions had lengths greater than 30 centimeters. So, procedural success. The procedural success was defined as having an end result of a residual stenosis less than 30% and without any associated complications. So here you can see that clearly the patients under the laser arm had lesser residual stenosis and greater procedural success when compared to standalone balloon angioplasty, which was statistically significant. And as you remember earlier, that Spectranetics makes 2 of these catheters, the Turbo Elite and the Turbo Tandem. In this trial, 80% of the catheters used was the Turbo Elite. So procedural complications, if you look at all the bar graphs on the left hand side, all the way up to bailout stenting, you can notice that clearly there were far fewer procedural complications in the laser arm with regards to procedural TLR, dissection, grade C dissection, bailout stenting. And as far as embolization, thrombosis and abrupt closure goes, there wasn't any significant difference. Now, looking at the primary safety endpoint, the two bar graphs on the left-hand side represent the intention to treat protocol. So, the intention to treat protocol means when the patients are randomized into two different groups, the analysis done at the end of the trial, which represents intention to treat analysis, is only those patients who were in that group. Now, these patients may have started in this group and then crossed over to another group. They are still analyzed as belonging to the original group. So this is called intention to treat analysis. And then the bar graph on the right hand side, which is called the per protocol. Per protocol is essentially analyzing those patients who received the specific treatment. So they may have started from the standalone balloon angioplasty and then switched over to the laser, but their analysis will be based on whether they got the laser or they got the balloon angioplasty. So it's not where they originally started, but what they actually got. So whether you analyze in the intention to treat group, whether you analyze with intention to treat without bailout stenting as TLR or per protocol, clearly the patients under the laser group did far more better than the standalone balloon angioplasty. Now, they also included bailout stenting by excluding it. The reason is if a patient was undergoing balloon angioplasty, had some kind of dissection which was flow limiting and needed a stent, then you may say that this probably biases your TLR results. So therefore they did the analysis by excluding those, and still it was statistically significant. And primary efficacy endpoint, which is essentially freedom from target lesion revascularization at the end of 6 months, essentially showed that the results were superior with the patients who received the laser treatment. And these are some Kaplan-Meier survival curves where they looked at survival which was freedom from target lesion revascularization. The blue line is representative of those patients who received the laser treatment, and the yellow line is representative of the balloon angioplasty patients. And clearly, the patients who received laser did way better than the patients who received balloon angioplasty. And similarly, when you looked at TLR without bailout stenting, so giving the benefit of doubt for standalone balloon angioplasty, despite this adjustment, you still see that the patients who received the laser treatment had a better outcome than patients who just got standalone balloon angioplasty. And with similar encouraging results found on the primary patency rates. And with regards to freedom from major adverse events, all the way up to a year, they found that again, the patients who received laser therapy did better than the patients who received balloon angioplasty. And in this Cox proportional hazard subgroup analysis, what they wanted to see was if lasers showed similar beneficial results across all the groups based on some clinical segregation based on lesion characteristics and certain demographics. What they found was essentially through all the groups except for diabetes, the patients who got laser treatment did better than who just got standalone balloon angioplasty treatment. Then with regards to lesion length and target lesion revascularization, clearly you can see as the lesion length increased, patients who received laser therapy did better than who received just standalone balloon angioplasty. So the conclusions of this trial was patients who received laser therapy along with balloon angioplasty treatment for in-stent restenosis had superior outcomes in both safety and efficacy when compared to patients who received just standalone balloon angioplasty. And this was again in the femoropopliteal segment. So as we know, the lesions were complicated, averaging 19 centimeters in length. They had a significantly higher procedural success rate and, as mentioned earlier, a higher safety rate and a higher efficacy rate with lower rates of TLR in the patients who received the laser treatment. And this is the first FDA approved device exemption randomized control study, which demonstrates the benefits of atherectomy in the lower extremities. Thank you for your patience.